Global Health and the Coalition for Global Hepatitis Elimination. And of course, allow me also an internal note to thank our team at the Embassy. Several of them are here, and it's only possible to organize this kind of events because of them. And among them, of course, especially Maria de Jesus Espada. Muito obrigado, Maria de Jesus. So, the headline figures for WHO 2024 Global Hepatitis Report, released in Lisbon on April 2024 at the World Hepatitis Summit, are very clear. New data from 187 countries, so almost all the countries in the world, show that the estimated number of deaths from viral hepatitis increased from 1.1 million in 2019 to 1.3 million in 2022. From 2019 to 2022. The same number of people killed by tuberculosis, second only to COVID-19 as the leading communicable cause of death. Worldwide, the burden of hepatitis C virus infection remains very high, despite some progress that we have been witnessing in the last decades. The high prevalence of hepatitis C, especially in vulnerable groups, may compromise the achievement of the 2030 WHO targets of a 90% reduction in new infections and a 65% reduction in mortality. Elimination of hepatitis seems feasible with the implementation of a massive therapy program, focusing particularly on vulnerable populations through micro-elimination strategies. Now some words about what we are doing in Portugal. In Portugal, the National Priority Program against viral hepatitis has established an independent hepatitis program for the first time. Hepatitis became one of 12 national priority programs. Portugal is one of the few countries with universal hepatitis B burst dose vaccine. As to hepatitis C, we have the HCV screening available at around 3,000 community pharmacies. Two studies have shown that the anti-HCV prevalence has decreased from 0.54% in 2020 to 0.3% in 2023 in Portugal. We have also developed peer-led programs and strong outreach and advocacy campaigns by community-based organizations, and we have removed all restrictions for oral HCV treatment. At the same time, Portugal has adopted national anti-discrimination laws against persons living with hepatitis B and or C, as well as a national policy for adult hepatitis B vaccination. The first national supervised consumption site has opened in 2021, and we also have national programs for HCV, HBC, and HIV treatment in prisons. Finally, it is also worth noting that our government has strong cooperation with NGOs to provide community-based services to reach vulnerable populations. And let me also say that it has been an honor for Portugal to work with the Coalition for the Global Hepatitis Elimination and to be a member of the leadership circle of the Group of Friends to Eliminate Hepatitis since 2022. And now, it's my pleasure to give the floor to Dr. John Ward, Director of the Task Force.
Thank you very much. First off, I do want to thank Ambassador Duarte Lopes for opening his home to us for this event, and so we can share our ideas and ways forward for hepatitis C elimination. I want to thank the government of Portugal for serving as a leader of this UN Group of Friends to eliminate hepatitis, and thanks to that leadership, that group has grown to over 41 countries, stepping up and expressing global solidarity in their commitment to doing what it takes to eliminate hepatitis. And it's sort of in that spirit of global solidarity that we're turning our attention today to the United States, a country with one of the largest burdens of hepatitis C around the world, to see what can be done. I began to work on hepatitis and hepatitis C prevention and now elimination almost 20 years ago when I was serving as the director of the CDC division of viral hepatitis. And when the FDA licensed these new antiviral therapies for hepatitis C in 2015, it was really transformational and opened the door to making elimination of hepatitis C possible. And that experience since then has shown those drugs to be incredibly safe, incredibly convenient to take, and can cure over 95% of people with just 2 to 3 months of treatment. And multiple studies have shown that the programs that make those drugs available are cost-saving for those countries, including the United States, which I'm sure you'll be hearing about in a moment. Now, the United States hasn't done anything. We've responded. You know, when those drugs were shown to be so highly effective, here at CDC, we recommended testing for all baby boomers because of their extra risk of being exposed to the virus through blood exposures before the virus was discovered. That was particularly important for Vietnam War veterans because of their extraordinary exposures to those kinds of blood that's been contaminated with the virus. And so the country made a strong commitment to assuring that testing and treatment was available for all of our military veterans. And as a result, hepatitis C has been virtually eliminated among veterans in our Veterans Administration medical system. So what we're really seeking to do now is to take that leap forward and making that testing and treatment widely available throughout the country so that every citizen can have that kind of access that has shown to be so effective for our military veterans. Now, about 5 years ago, I moved over to the Task Force for Global Health and began to work with countries to see how we could do our part in helping them stand up programs for hepatitis and hepatitis C elimination. But in that work, I began to gain experience from countries that were showing a strong national commitment to hepatitis C elimination and putting together highly effective programs that were accelerating their progress toward hepatitis C elimination. And with that continued interest in hepatitis C elimination in my country, I thought, well, we really need to start bringing back those kind of key lessons learned and key effective strategies that can help us do our work. So that's really where we are today, is to, in that spirit of global solidarity, to share those kinds of experiences. So over the next few minutes, we're going to make all of you experts in hepatitis C elimination, if you're not already. You're going to be hearing why hepatitis C elimination is possible from the good science that started our process toward this. You're going to hear about what needs to be done to eliminate hepatitis C in the country. Then we'll be hearing from our colleagues from Australia, Mexico, and Great Britain about how they are out in front in eliminating hepatitis. And then we're going to have some thoughts about where do we go from here to achieve those goals for hepatitis C elimination. And I would like all of you to leave here with as strong of a conviction as I have that hepatitis C is eliminatable in the United States as it is being done in other parts of the world, as you'll be hearing about. So thank you again for attending. So I think I'll turn it over now to my dear colleague, Dr. Harvey Alter, who's been a scientist at the NIH for many, many years, and with two of his colleagues, Michael Houghton and Charlie Rice, was awarded the Nobel Prize in Medicine and Physiology in 2020 for their work that led to the discovery of the hepatitis C virus that was first reported in 1989. Harvey?
Yeah, good. I think I never talk sitting down. This is that's it. Thank you. These are nice glasses, by the way.
Don't have Portuguese wine in a while.
Well, I had the privilege of seeing the first patient who was diagnosed with having some new hepatitis virus. Something we hadn't seen, wasn't A, wasn't B, and we initially called it non-A, non-B hepatitis. But then as we knew more over the years, it got renamed the hepatitis C virus. When I first saw this patient, he was totally asymptomatic. In fact, felt so well that we picked him up as he was volunteering to donate blood, and we tested the blood and it was found to be positive. I followed him over the next 20 years and unfortunately watched his liver progressively get more and more fibrotic, as shown by liver biopsies. And he wound up 20 years later with cirrhosis and hepatitis C related cancer of the liver, and died at that time. It was a very frustrating process to watch these patients, and you had nothing to do. We had a interferon, which was a very tough drug to use, and it was worse taking the drug than having the disease. So it was frustrating. But by studying more and more patients, we found that this progressive course occurred in up to 40% of people who had hepatitis C. The other 60% actually did quite well for as long as we followed them. But we're dealing with that number who might progress in this inexorable course to hepatitis C related death. In 2014, as John said, a miracle occurred. The pharmaceutical industry developed a drug like never before, a drug that now can cure 95 to 100% of patients, oral tablet once a day, virtually no side effects. There's just no other drug that does this to any disease. And I want to emphasize that this is a real cure. It's not just suppressing the virus while you're taking medication. This is a permanent cure. So this is a medical miracle, really, that I didn't anticipate would happen in my lifetime. Luckily, I lived long enough to see it. But now, as John said, we have a whole new world of possibilities. We have the tests, we have these amazing drugs, and we just have to get the patients, find the patients who need to be treated. So we've pretty much treated everybody in the country who knows they have hepatitis C. That part has worked very well. But it's finding the approximate 40% of people who are chronic carriers of C and are still asymptomatic. They don't know they have it, but maybe will progress over time. So Egypt has already proven that this theoretical possibility is a reality. Egypt tested 60 million people, almost their entire population, and treated those who were found to be HCV positive, over 2 million people, and has cured them all. So Egypt is now almost hepatitis C free. And they did it inexpensively, and we'll get into that part of it. Other countries in Europe and Asia, around the world, in Africa, are using the same test and treat strategy. It works. It's complicated, but it works. So as Dr. Collins will emphasize, the U.S. Still is lagging behind the rest of the world. We have states like Louisiana who've done this, have used this strategy, and it's been very effective. But as a whole, we don't have a national policy to eradicate hepatitis C. I think for a relatively small investment, as government money goes, we can do this. We can test these people and get this done. Think about it. If you think about it, hepatitis C would be the first chronic infectious disease to be cured by treatment rather than prevented by a vaccine. We don't have a vaccine per se, but it's the only one that can really be cured once it's chronic, and that's an amazing thing. So we can do this. We can. All it takes a lot of effort. There's no doubt about that. But mostly it takes the moral commitment to make it happen, to know that it's the right thing to do, and also that it can be done. And that's why we're here today. I think if we can just realize the potential, it's sort of a no-brainer. But it's not easy. But I will bet, I mean, it's already been proven it can be done, and America certainly can do it. So Francis will tell us where America stands.
Well, thank you, Ambassador, for inviting us all to this beautiful space to talk about this really critically important issue. And thank you to all of you who've decided to come and spend time on this topic of hepatitis C. I'm Francis Collins. I served as the NIH director here in the United States for 12 years under 3 presidents. I was then asked to serve as the president's acting science advisor. And one of the opportunities that the science advisor has is to look across the whole landscape of what's happening in science and medicine and say, is there something that we could do but we haven't quite pulled together? And what rose very quickly to the top of that list was, let's eliminate hepatitis C. We have the capabilities across our amazing country to do this, but we hadn't quite figured out how to put all the pieces together. And I will tell you, I have become obsessed about that for the last 2.5 years, along with a lot of my colleagues. And I'm glad a couple of them are here. With the small but mighty team that I'm part of working for the White House aims to try to see if we could actually get this done. And consider what it means if we don't. 40 people will die in the United States today of hepatitis C. That number should be 0. We have a cure. We've had a cure for 8 or 9 years. My brother-in-law died of hepatitis C. And let me tell you, those last 3 or 4 years of the end stage of this disease is truly grim. You heard about that from Harvey. We should not be able to look away and say that's okay. But there are 4 million Americans right now, CDC estimates, who are infected with this virus actively in their liver, and without intervention, a significant number of them are going to end up in this very difficult place of liver cirrhosis, liver failure, and liver cancer, all of which is preventable because we have this amazing cure. The development of these direct-acting antivirals, I would judge, is one of the most major significant achievements of medical research in the whole world in the last 20 or 30 years. A pill that you take 1 a day for 12 weeks, 95% cure, and you're done. You are done. It's not like one of those where it's the rest of your life. And the side effects, as far as anybody says, are pretty much not there. So why haven't we taken care of this? It's a complicated issue. How do you get hepatitis C? You get it from contaminated blood, a blood transfusion, as Harvey was talking about, especially back in the day when we didn't know how to screen blood units for hep C. Now, thanks to Harvey and his work, and hence the Nobel Prize, we do that. But it's still possible to get this disease in other ways, from contaminated needles. And certainly at the present time, in this country and in many other parts of the world, the most rapidly growing area for new cases is people who've gotten caught up in the intravenous drug circumstance, which is all too common in many of our countries and our communities. If you go to one of the opioid treatment centers in this country, and you actually ask people, are you willing to have this test done? And you find out what proportion of them are hep C positive. Some of those treatment centers, it's 50%. I heard one it was 70%, because a shared needle, because this is so infectious, just rapidly happens. And those people are getting their lives back together, and they're gonna go back out and be functioning members of the community only to have lying ahead of them this dangerous virus that may very well take their life prematurely in a very awful way. This is not the way it should be. The good news that I have to tell you about the US is after a bit of a slow start, we have not distinguished ourselves up until now particularly, other than some very impressive work that's been done in a couple of the states, and Louisiana already got mentioned as a good example. For the most part, because it's hard to figure out how to reach some of the folks who most need this, because testing hasn't been done, so a lot of them don't even know they're positive, and because the cost of the drug has been quite high, most people who don't have third-party insurance or who are not on Medicare may be having trouble getting access. Even on Medicaid, because of all those various issues, barriers have been put up in many states so that you don't get access to the cure unless you're able to show that you already have liver disease. Doesn't that sound upside down to you? Or that you have to prove that you are in fact completely abstaining from any kind of drugs for at least a year. Or you have to see a specialist. I'm an internal medicine doctor. Let me tell you, this is like one of the simplest, most remarkable opportunities for medical care, delightful joy that you can think of. You can cure somebody with a simple bottle of pills over 12 weeks. And yet, barriers are put up saying, oh no, you gotta see the experts before you can do this. Those should not be there. So what's the plan? The plan initially put forward by the Biden administration a little over 2 years ago, over a year ago, April of 2023, had 3 parts. We've already done one of them. One part was to do what Australia and some of the countries in Europe have been doing all along, which is to make the testing simple. At the moment, until this was all looked into in the US, it took 3 visits to the clinic before you found out that you needed the treatment, because you had to have an antibody test, and then you had to have a viral RNA test. And those had to go off to some laboratory somewhere, and the results would come back sometime. And we lost a lot of people along the way because they weren't feeling sick. Like, what are they talking about? I got to come back again? The test that's now been approved by the FDA with a very impressive partnership with FDA and NIH is a test which is a finger stick, it's point of care, it gives you an answer in less than an hour. Now we can do test and treat, 1 visit. Finger stick, oh, you're positive, here's your bottle of pills. That is a game changer, and that is already in place. And again, much credit to FDA and NIH and their partners and CDC, especially for making that happen. The other things we need, and which are now part of a bipartisan legislative effort being championed by Senators Cassidy of Louisiana and Van Hollen of Maryland, and some of their staff are here, and I can't tell you enough about how hard these folks have worked to get us to this point. We need to have a way of getting the healthcare delivery system revved up so that if you are somebody who is uninsured in a community health center, there is an effort to reach out and find out whether you have this, and if so, get your cure in your hand. Or if you're in the prison system, where again, hepatitis C is quite common. Or if you're somebody on the Native American reservation, where we know that hepatitis C is also common. All of those need special attention in terms of healthcare outreach. But we also need to come up with a creative way to deal with the cost. And this is building upon the Louisiana plan, which we have looked at very carefully since it was started in 2019. And this is what's called the subscription model. And Gilead agreed to this on a statewide basis, basically that they would accept a lump sum to be able to make the drugs available for people in Medicaid and people in the prison system. But it was a lump sum that was paid up front, so then it was done. And then you had every motivation to go and find everybody who's hep C positive and get them the cure. That's what we want to see on a national level with the companies, Gilead and AbbVie, we hope, willing to take part in that kind of an opportunity. And they should do fine in this. This ought to be set up in such a fashion that everybody wins. The government wins because a lot of healthcare dollars get saved. I'm coming to that in a second. People, most importantly, win because they get cured, and the companies also do just fine. Now, what about the healthcare savings? This is a big issue, and it's the one that's right now hanging in the air. The initial analyses done by economists working for places like Harvard would say that if you can find all of the folks out there, the 4 million or some significant proportion of them, and get them cured now, you're going to save billions of dollars that you won't have to spend on liver failure, liver transplants, liver cancer, which are all very expensive. But in our country, The Congressional Budget Office is the official arbiter of these such things. And they've been hard at work at that analysis since January. I think a couple of their staff may be here. They've been working very hard, and we've had really good conversations about all the details here. And we are hopeful, and have some reason to be hopeful, that their analysis will be coming forward relatively soon, in the next few weeks. Now, if they decide that this is not only a great compassionate thing to do, but it actually is going to save significant money in a 10-year period, then what's not to love? Yeah. If you can do both of those things, even in a complicated political environment, which we sort of have, it ought to be possible for almost anyone to wrap their arms around it and say, we just gotta do this. And then maybe the United States won't be the last one to come along and solve this problem, that some of the other countries represented here have actually been doing better than we have. But I think this is totally achievable. I think it's achievable this year, in the next few months, if everything comes together the way it looks like it could. But it's going to take a lot of determination, a lot of motivation, which is why I'm glad to see all of you all here. Spread the word. We can eliminate a disease.
Francis again for his strong leadership. You can see he's totally invested in this, and one of the reasons this is going to be successful is Francis's leadership in this. But now let's hear from some of our colleagues from the other countries, just to give you an idea of how hepatitis C can be eliminated. We're going to start off with Emma Wilson, who is from the Australian Embassy here in D.C. Up to you.
Okay, I'll stand. Thank you, Ambassador, for the invitation to the Australian Embassy to speak. We're really delighted to be here. Thanks also to John Ward and your team for your assistance in preparing for this event. You've been a great partner and friend to Australia. And I'm very pleased to share key features of Australia's national model for hepatitis C elimination. The model has had remarkable success in more than halving the number of people with hepatitis C in Australia. We have significantly reduced the incidence of hepatitis C in high-risk populations from 53% to 12%. To put it another way, we have achieved a 57% decline in HCV prevalence, a 63% decrease in new infections, and a 30% decrease in mortality. So how did we manage the 57% decline in hepatitis C cases? We have a strong health system, and that's foundational to our success. On hepatitis C elimination, we have invested heavily in world-leading research to develop treatment and testing tools to fight the disease and improve health service delivery. However, first and foremost, we attribute this outcome to unrestricted access to hepatitis C treatment provided by the Australian government. The Australian model includes no access restrictions based on prescriber type. That means you don't need to go to a specialist to get access to HCV therapies. And there are no access restrictions based on liver disease stage or drug and alcohol use. Unrestricted access was enabled by the subscription funding model of purchase for HCV therapies. Under the subscription model, the Australian government worked with pharmaceutical companies to negotiate a fixed payment for therapies in exchange for an unlimited volume of HCV medication, as we just heard from Francis just now. The subscription model went hand in hand with Australian government subsidies for hepatitis C treatment, with only a small co-payment required from patients. This resulted in the equitable uptake of hepatitis C treatment, with people who inject drugs and people who are incarcerated as likely as the broader population to have received treatment. In fact, those from marginalised populations are slightly more likely to have received treatment in Australia. Research has shown that the Australian subscription model successfully provided medication for an additional 100,000 patients, noting we have a population of about 25 million. And also saved the Australian government about $4.5 billion. Because of the delivery of hepatitis C treatment to this high volume of patients, Australia is well on its way to hepatitis C elimination. Australia's efforts are aimed at achieving the global goal set by the World Health Organization to eliminate hepatitis C by 2030. The partnership model underpinning Australia's national hepatitis strategies has also been a key feature of our success. Our strategies mandate collaboration between governments, community, research and clinical bodies. This year, Australia will launch its 6th National Hepatitis C Strategy, which represents our last big push to eliminate hepatitis C as a public health threat in Australia by 2030. Our new strategy is conceptually different from previous iterations, expanding upon the cascade of care to adopt a more comprehensive, person-centred, community-led approach to hepatitis C elimination. It also centres our national response on concepts such as whole of person, whole life course, and social and structural determinants of health. Australia has been proud to lead the way in the elimination of hepatitis C. I thank you for the opportunity to share details of our efforts, and we hope that our experience has provided lessons for others to follow. Thank you.
Thank you, Emma. I'm sure all of these remarks are perhaps raising some of your own thoughts and questions, and we'll have ample time to talk among ourselves after these remaining comments are through. So let's turn now to my colleague Alethse de Rosas Torres from Mexico, who's responsible for the HIV and hepatitis program for the Ministry of Health, and he has graciously come to Washington, D.C. to share with us the progress toward elimination of hepatitis C in Mexico.
Thank you, and I think I need to sit down and use these beautiful glasses as well. So, good afternoon, Your Excellencies, colleagues and friends. Thank you, John, thank you, Ambassador, thank you, Harvey, and all of you. It's an honor to be here amongst people who are deeply committed to make the difference for the local, national, and global population in the elimination of hepatitis C. And it's exciting because with a national government commitment and a pragmatic yet based on evidence approach, we can change the future for this public health threat with a framework that is feasible even for low and middle income settings, just as we're proving in Mexico in our journey towards the elimination of hepatitis C. In the next 2 minutes, and let me share with you 10 basic steps that we have implemented in order to leapfrog and improve our national outcomes since 2019. Number 1, be bold and have a public health approach. The program started by gathering information about the cost and impact of hepatitis C over the previous decade and aligning all the public health providers with our new framework and goals. This allowed us in 2019 for the change of purchase agreements from a fragmented demand case by case to a Netflix type national strategy. In turn, this meant that every single patient cost less to the government, which allowed us to launch and maintain our framework of 4 main pillars. A, universal free of cost access to HIV, hepatitis C, and also HIV, screening, diagnosis, and treatment for all people in Mexico, migrants included, and not only for high-risk groups. B, a primary healthcare approach, unifying actions independently of the public healthcare provider, regions, and states. C, social communication and telementoring strategy. D, introduction of a universal online registry to measure the health outcomes that are important to people, as well as to promote benchmarking, direct improvement strategies, and research. Number 2, encourage leadership and networks. We started the implementation of the pillars in 2020. You remember what happened then. At a highly complex time for all health institutions globally. Thus, only by having a program created and implemented with and alongside the communities could we advance. We created an observatory group where regular online meetings are held with healthcare authorities, academic, public health, and community leaders. This allowed people to think about options and solutions to help advance the program from different perspectives. Number 3, simplified guidelines. To be able to have a primary healthcare approach, we developed a simplified evidence-based national guidelines, but we needed to remember that we are not dealing with a virus, but with people. Thus, other elements such as mental health and substance use, diagnosis and treatment were also included. Number 4, scale up quickly a primary healthcare approach and make this public. In 2019, we had less than 60 units across the country to treat people with hepatitis C. Now we have almost 2,000, the vast majority in primary healthcare clinics. People are able to search for their zip code, which provider is closer to them. National campaigns are a great way to boost people's awareness, bringing services to people. Number 5, train and mentor healthcare providers. Training of primary healthcare workers is essential. By telementoring them, in some cases, we can ensure that the specialists are also involved in decisions and they can learn and be empowered. We have developed online courses with over 300,000 healthcare workers trained and have both medical leaders, specialists in hepatology, infectious diseases, mental health, who help clinicians across the country reducing access barriers. Number 6, have a standardized person-centered registry. Having a minimum standard set of health outcomes that follow the person is essential to monitor, benchmark, and ensure the program is improving. Make this public to encourage learning and accountability. Number 7, set and communicate your goals. Every population is different. We're starting during the pandemic with a low-hanging fruit with people with HIV and hepatitis C co-infection. However, since then we have reached other populations, including people in jails, people who use substances, people in hemodialysis, hemophilia, army forces, indigenous populations, and now general population of high incidence counties. Number 8, verify your actions in territory. The only way to improve is to understand where the gaps are, and this can be achieved by going to the states and medical units themselves and involving the different actors. Continuous improvement cycles have helped us to keep on track. We have implemented a task force in each state. They are in charge of helping providers to improve. Number 9, benchmarking. It's essential to share and to copy from others. Mexico is committed to eliminating hepatitis C, and so we looked and studied the approaches and strategies that other countries were implementing and were feasible to adapt them. That also now is happening in the local or even physician level. Number 10, innovation is key. Every single day, think about the people that we're not reaching yet and what can be done. Of course, no country has unlimited resources, economic nor human. Thus, we must ensure we take advantage of every single opportunity to integrate care and access. For instance, for people who have created programs in blood donor centers, for people who are rejected to donate for on-site, having on-site rapid tests, SWAT teams who are mobilized during campaigns or jail screenings and now offering rapid tests paid by the government in private laboratories and pools for hospital patients so no one escapes. All the 10 points are paid or led by the government, but the investment pays back. We have reached and tested over 8.5 million people, and more than 24,000 have received treatment with over 95% cure rate. We're starting to see changes in the morbidity, hospitalization, liver transplants, and mortality due to hepatitis C. And 2 months ago, we reached the number of treatments needed in our Netflix model to have the money back and returned to the government. And now treatment is free of cost in Mexico. So what else could we ask for? healthier population, and a reduction of cost investment for a country. It's the core of value-based healthcare. So the message is clear: global, regional, national, and local commitment with a focus on health equity and public health is crucial for advancing hepatitis C elimination. Thank you.
Live TV here. Well, thank you very much for that cookbook, for the recipe for hepatitis C elimination in Mexico, and it also reveals the importance of having national champions such as Alethse is for Mexico, and so thank you. So now let's turn to Jade Stocks, who's with the Great Britain Embassy here in Washington, D.C. is going to give us some lessons learned coming from the successful program in England.
Thank you, Ambassador, for your hospitality and for everyone else for joining us this evening. I'm pleased to provide you with an overview of the steps the United Kingdom has taken towards eliminating the harmful impact of hepatitis C. We have made significant progress in fighting this disease through political commitment, centralized funding, localized delivery, and innovation. This includes strategic partnerships with antiviral drug manufacturers and testing services that actively address the barriers and stigma encountered by people at high risk of infection. Since 2015, when highly effective direct-acting antivirals became available, chronic hepatitis C prevalence in the United Kingdom has fallen dramatically, with a decline of over 51% in the general population and over 60% among people who use intravenous drugs. Access to antivirals is unrestricted and free of charge at point of delivery. Mortality from hepatitis C has declined to its lowest rate for the past 10 years and surpasses the WHO's target. Key to this decline was the country's investment in a nationally coordinated specialist hepatitis C elimination program to improve access to testing and antiviral treatment. Between 2015 and 2022, 81% of diagnosed individuals with chronic hepatitis C were connected with specialist treatment services, and nearly 80% of those started treatment, resulting in over 77,000 treatments initiated in this period. Close partnerships have also been crucial. Our National Health Service has led a long-term procurement deal for antiviral treatments, with the pharmaceutical industry contributing their expertise to locate those with undiagnosed hepatitis and linking them to care. Drug service providers and the third sector work closely to offer peer support, helping people affected by infection navigate the system and remain engaged in care. Our prison service collaborates with a national patient organization, the Hepatitis C Trust, to deliver mass test and treat events, offering every prisoner a hepatitis C test during their sentence and providing rapid access to treatment for anyone diagnosed. This rapid find and treat delivery model has now been adopted by some regional specialist services to offer advice and on-the-spot antibody testing to the most vulnerable people in the privacy of their own homes or in community outreach vans, some of which also provide services such as liver health checks. We also introduced a free national online portal where people can confidently order hepatitis C self-sampling kits directly to their home, confidentially. We are also piloting a multi-pathogen approach, providing opt-out blood-borne virus testing in 33 emergency departments based in areas of high and very high HIV prevalence. In its first year, nearly 1.7 million tests were submitted, and almost half of these were for hepatitis B and C. This has resulted in hundreds of people being newly diagnosed with hepatitis B or supported to re-engage into care. Collectively, these models of delivery diminish the stigma of all blood-borne infections and enhance the accessibility of testing to reduce geographic inequalities. Despite our progress, there is still much more to do if we are to continue to reduce the prevalence of hepatitis C infection and to exceed the WHO's elimination targets by 2030. New and reinfections continue to occur among people who use intravenous drugs, indicating that more needs to be done to prevent infections, including ensuring the adequate provision of opiate substitution therapy, as well as sterile needles and syringes. Other next steps include, first, improving access to and uptake of treatment across the health system, including mental health services, drug treatment services, prisons, homeless services, and pharmacies. We are working to simplify the referral pathways and strengthen continuity of care, especially from prison to the community. And two, strengthening monitoring activities, such as providing interactive, real-time data dashboards for use by local medical teams, or use of monitoring data for direct patient care and evaluating interventions to ensure we continue to deliver the best value for money. As we move to the final stages of elimination of hepatitis C in the UK, we are further developing and outlining approaches to testing, surveillance, and pathways of care required to best sustain our progress and ensure early detection of future threats. Thank you.
Thank you all. I was just thinking to put this sort of into perspective. Let's say right now we tested everybody in this room, and with this needle stick, finger stick test, then you went out for an hour and had cocktails. You came back, that time we had your results, and we found that every one of you was positive. So we then give you 90 pills. You take them one a day, and in December you'll all be cured. That's the story, really. It just you can't conceive of this except that it's real. So in December you come back, we have more cocktails, and you'll never have any
I think we can all drink to that, for sure. Is Mr. Sam West here? Oh, there you are. So, Sam here is representing Senator Bill Cassidy, who has been a longstanding champion of hepatitis elimination in the U.S. Congress, first as a representative and now as a senator from Louisiana. We very much appreciate Sam coming today. Thank you, sir.
Absolutely, and thank you all, and thank you, Mr. Ambassador, for hosting this. You know, we were excited about this event because hepatitis C elimination is something the Senator is personally very passionate about. He was very focused on the original Louisiana model when that was first getting off the ground and designing the contours of that model. And it was informed, frankly, based on a lot of the work internationally that had been done in Australia and in others. And trying to understand how can we take those models, how can we take what works well and bring it to the United States in a very limited way in the state of Louisiana, and start treating a state that has traditionally some of the lowest health outcomes for low-income and uninsured individuals in the country. So we tried to take that and we tried to run with it. And Louisiana had a lot of success, but Louisiana didn't have the scale, didn't have the scope to sort of meet the entire needs of the population, despite, by the way, a tremendous effort on their part. So when Dr. Collins, and I want to give a lot of credit to Dr. Francis Collins for his incredible advocacy here and making this all happen. When he came to the Senator and pitched us and Senator Van Hollen on the idea of replicating the Louisiana model, replicating what some of our colleagues internationally had done, but doing it on a much larger scale, doing it nationwide, and looking at individuals in correctional settings, looking at individuals, low-income individuals on Medicaid, looking at seniors on Medicare, and individuals on drug and rehab facilities. Looking at them all and saying, how can we have a national strategy to reach each of these people where they are? And we know that it's much more difficult to reach these populations in general. Historically, and I think this is true internationally, these are often the most difficult individuals in a health system to reach. And when you are able to reach them, you have to be able to reach them again and again and keep them integrated into the system. And he came to us and said, what we need to do is we need to look at each of these populations individually, and we need to say, how can we come up with a strategy to treat this person? How can we come up with a strategy to treat this person? And he said to us, what we're going to be doing is working to get a point-of-care diagnostic on the market here in the US quickly, and he has, and in good coordination with manufacturers there and the folks at the FDA and NIH, and said, how can we use that and leverage it so that when we have somebody in the doctor's office, when we have somebody in a corrections center, we don't have to give them another appointment and say, come back in 3 weeks, come back in another week. If you do that for many of these individuals, you will never see them again. And we wanted to be able to say, how could we treat them immediately? So, you know, Dr. Collins innovated that. We have worked on it. I think we are very encouraged by the initial signs we've seen from CBO. We're very encouraged by numbers coming out of Louisiana still, and again from our colleagues abroad. And we think that this is very doable. I would describe our attitude as cautiously optimistic this year, that this is something which can be done. It's dependent on SCORE. It's dependent on the policy saving money and making sense for sort of the current political context that we're in. But we think that we have a good chance. So that's all to say, really appreciate the work you all have done, appreciate your leadership, appreciate so much the groundwork you all laid to even make this possible. Mr. Ambassador, for hosting. You know, we are excited about this. We appreciate your partnership, and we look forward to getting this done this year.
Thank you. So those are exciting words that you are optimistic, and so we will be optimistic with you and do what we can to help you with that. And hopefully you've heard some good examples that you can take back and let everyone know that progress toward hepatitis C elimination is possible and is happening elsewhere, and we can accelerate the progress here. I know we're a little bit over time. I really appreciate all of your attention. I challenged you all to become instant experts. I think we've given you the information to do that. Can we see a show of hands for people that think we can eliminate hepatitis C in the United States, please? One more time. Thank you very much. Okay, thank you. Do you want to say some closing remarks, and then we can have some cocktails and chat among ourselves? Thank you.
Yes, thank you. Thank you very much, Dr. Ward. And let me, again, thank you, all of you, for being here with us today. I learned a lot, and I mean, my commitment and my engagement is now even reinforced. So you can keep on counting on us. And when I say us, it's of course Portugal, but also the embassy. So
Thank you.
use us anytime also to keep on this effort. Dr. Alter, we are very sorry that we forced you to dance with the microphone once in a while. So now some cocktail will be served outside. Just before we go, let me tell you two things as we are in this room. Two notes. So one about the piano, one about this portrait. This gentleman portrayed there was ambassador of Portugal to the US between 1816 and 1820. One of our first ambassadors. And because we are speaking about science also here today, he was chosen not because he had a lousy law degree like this friend of yours. He was chosen by then because he was one of the most prominent scientists, biologists in the world by then. His name was José Francisco Correia da Serra. So, now very quickly about the piano. I hope there's somebody in the room that plays well the piano, or that plays the piano. Because now you'll have the chance to play here if you want. In this piano came from New York, from the Dakota building, where we used to have an apartment. The previous residence of the Portuguese ambassador to the UN was an apartment at the famous Dakota building, where, as some of you know, John Lennon was also living. So there's a good chance that John Lennon. So take your chance also.